Since 2015, PopHealth Podcast has brought to you some of the best minds in healthcare, including leaders from government, not-for-profit, and investor-backed powerhouses, as they share successes, failures, and how our audience can move forward in today's constantly evolving healthcare world. Thank you for joining us for today's episode presented by 24 Hour Home Care. Hello, everyone, and welcome to another episode of PopHealth Podcast. I'm Gavin Ward, host of PopHealth Podcast. In today's episode, we had returning guest Dr. Takashi Wada, who serves as the Chief Medical Officer for Inland Empire Health Plan, a local initiative health plan that is insuring and serving more than 1.6 million members in the largest geographical counties in California for a health plan, which are San Bernardino and Riverside counties. In today's episode, Dr. Wada shares a little bit about what he saw in year one of CalAIM, which is the California Advancing and Innovating Medi-Cal, and what is coming down the pipe in year two, including a focus on individuals transitioning from nursing homes to the community and a continued effort for those who have experienced homelessness or the just-served population as well. We hope you enjoyed today's episode. Feel free to check out other episodes of PopHealth Podcast by visiting us at pophealthpodcast.com or checking us out on YouTube or just wherever you listen to your podcasts. Thanks, everybody. Enjoy today's episode. Dr. Wada, thanks so much for joining the show again today.
Great. Thank you for having me again.
Absolutely. So folks, for those of you that haven't seen or heard Dr. Wada's episode, we actually had him on about a year ago when CalAIM or the California Advancing and Innovating Medi-Cal was brand new. So one of the reasons we invited Dr. Wada back was to hear about the results of year one and what's to come in year two. But before we do that, even though Dr. Wada, you are a repeat guest, we always like to kick it off with getting to know you a little bit. I know many of our listeners or viewers may not have seen or heard the first episode, but regardless, maybe something different than last time, maybe something about yourself that might surprise the audience.
Sure. I was giving some thought to the fun fact, and there were several that came to mind. But after thinking about it more, I don't know that I want them to be public and living forever on the internet. So
exactly.
I'll stay with something pretty safe, which is my Spanish is a lot better than my Japanese. So I'm Japanese by heritage, but my wife is Mexican-American, and I've also spent some time doing international work in Mexico and South America. This was even back before I was married. I used to, when I was working at UCLA, I used to help run a student-run clinic just over the border in the city of Tecate. We'd take a bunch of undergraduates and medical students from UCLA, some residents, and we would go there every few months to run a little border clinic. We'd take supplies and medications. But I've also worked further down in Mexico in the state of Nayarit and Chiapas, and also in Peru, doing some international work.
Nice. So let me ask you, your Spanish is better than your Japanese. How about your food taste? Do you like Japanese food better, or do you like more south of the border, Mexican, South American food?
I pretty much eat anything.
Oh, that is, your wife and family are lucky. Very good. Yeah.
Anything except alpaca. So I don't know if you know what is alpaca.
I've heard of it, but
it's an animal down in Peru. Looks kind of like a llama or llama. And when I was doing international work in Peru, I initially signed up to go work down in the Amazon. And there happened to be an outbreak of dengue fever, and I didn't really want to go expose myself to that. So I got hooked up with a group going up into the Andes Mountains, which was very, very high altitude. And I was not prepared for that. And so I ended up getting pretty sick from the altitude sickness. And also I didn't have any of the appropriate clothes. But for some reason, one of the only foods I could eat was alpaca. And so I would eat alpaca breakfast burritos, alpaca sandwiches for lunch, and alpaca steaks for dinner. And I wore alpaca fur clothing because I didn't have anything warm. And after that, I swore I would never eat alpaca again.
And have you stuck to it?
Yes. Yeah.
Nice. Well, let's actually, before we jump into year one and maybe giving the audience a little bit of a reminder of who Inland Empire Health Plan is, staying on this personal side, how's the last year been for you outside of work? Have you, I know some people might argue we're still in the pandemic, still not. I know you have a family. Any personal highlights you'd like to share with the group before we jump into the business and healthcare side?
Yeah, nothing that really stands out. Just another year, married to my wonderful wife. Kids are a year older. I'm in my 50s, so I got my screening colonoscopy. That I thought about that. I guess lead by example. So that everyone gets their screening done. It's always good to do your preventive care. But yeah, nothing really stands out.
Okay, good. Well, it sounds like overall things are going well for you, Dr. Wada. So let's go ahead and jump in to what's been happening at IEHP or Inland Empire Health Plan. Now, I know many of our listeners or viewers, Dr. Wada, are familiar with Medi-Cal and how that's basically Medicaid in California, and some may be familiar with IEHP or Inland Empire Health Plan, which is one of the largest health plans. Really, well, maybe not in the nation, but definitely here in California in seven figures. So give the audience a quick reminder of who IEHP is.
Sure. So Inland Empire Health Plan. So you're correct. We administer the Medi-Cal program or Medicaid for two very large counties here in California, San Bernardino County and Riverside County. The Inland Empire is huge geographically. It's about 27,000 square miles, which I believe is bigger than maybe 10 states in the country. It's a population of about 4.75 million. And of those, IEHP covers about 1.5 million members in our health plan. So about 30% of the population here has IEHP for their health insurance. About of those 1.5 million or so, we have about 33,000 that are dually eligible in both Medi-Cal and Medicare. We have about 3,000 employees, maybe more than that at this point. Over 7,000 providers contracted in our network. So we're a pretty big public health plan.
So you mentioned 3,000 employees. I know as the chief medical officer, some of those are under your team. Quick opportunity for a plug. Any roles you're hiring for your team or IEHP that's you'd like to share with the audience?
Oh, yeah, that would be great. Workforce is definitely an issue for us. And so we are hiring across the board, not just licensed healthcare in terms of nurses, social workers, but even analysts, administrative staff, coordinators. We do have a lot of openings right now.
Awesome. And if folks are interested, in exploring those, is it like IEHP.org or what's the best route? Okay.
Yep. Everything will be posted on our website.
Okay. Awesome. Thanks, Dr. Wada. So we talked about IEHP. Most folks by now who are listening probably know about CalAIM, but maybe like you did with IEHP, could you give a high-level overview of CalAIM again? I know you did last year too, but less in the weeds, just kind of a high level, and then we'll jump into some of the results.
Sure. So as you mentioned, CalAIM is an acronym. It stands for California Advancing and Innovating Medi-Cal. It's really a transformative multi-year initiative at the state level, and so the local health plans are implementing that. And it's really designed to improve the quality of life and health outcomes for Medi-Cal beneficiaries. It streamlines Medi-Cal. It really helps us to address a lot of social determinants or social drivers of health, really looking at our members from a whole person perspective. I'd say some of the bigger components, again, it works at all different levels of risk. So in our health plan language, we like to look at our populations and what we call risk stratify them. But really, CalAIM is working at multiple levels, and there are multiple components of that. So there are new tools that we can use for our members that are at the highest risk. So enhanced care management. These are community-based wraparound teams that can help with care coordination, addressing some of these social determinants, drivers of health. There are community services that we can now support, some things like housing, medically tailored meals. There are other pieces of the healthcare delivery that were what we call carved into our health plan, both geographically, areas that we didn't cover in our health plan that have been now added to our geographic coverage area, some additional services such as transplants that have been carved in so that we're now responsible for, instead of those going to the state, we're now responsible for that care coordination. There's a lot of emphasis on behavioral health integration, streamlining the payment system. There's a big new component around population health management. And this is looking at some of the other levels of risk. So ensuring that our members are engaged with their providers, primary care providers, because that's always an issue for us. A lot around preventive care, maternal child care, health education, disease management. So there are a lot of different pieces to CalAIM for sure.
Definitely. And again, I may have said it incorrectly, but it's California Advancing and Innovating Medi-Cal. I think I may have said Innovating and Advancing. So thanks for saying it correctly. And you were so humble and not correcting me. Yeah, I really appreciate that overview, Dr. Wada. So year one, I know with IEHP and with many health plans across the state, you touched on it. Housing was one of the initial focuses on many plans. In year one, are you able to share any of what you've seen as a result of your efforts when it comes to housing or any of the other community supports or enhanced care management, whether that's some facts and figures or stories? Member success stories are always good too.
Sure. One of the things when I talk about CalAIM and just sort of the social drivers of health, I like to sort of give a fictional sort of story about how it works and how it addresses some of these challenges. And so, what I like to start out with, as I mentioned, I'm in my 50s. I turned 55. And I have good health insurance. I'm a good job. I'm able to take time off to go see a doctor. I get my preventive measures like my vaccines, colon cancer and blood tests. And so, I decided to go get a physical exam, an annual checkup. And, the doctor says, oh, you have some borderline diabetes now. You got to eat better and exercise. So, but fortunately, I have the means to do that. I start shopping at Whole Foods, maybe get a nutritionist consult, join a gym, get a personal trainer, get a new bike to ride around the neighborhood, then go back in a few months to see the doctor again, get my follow-up tests, diabetes, blood sugar, much better. And so just ongoing monitoring. Now, say I have a fictional twin brother who's the same age. Unfortunately, he's had some bad breaks in his life, maybe had an accident, had some chronic pain, got addicted to opioids, smokes, suffers from depression, unable to work because of that regularly. Doesn't have great health insurance, has trouble with housing, so he doesn't live in the best neighborhood, lives next to a freeway, just takes part-time gig economy jobs, so he doesn't get paid time off from work. Maybe he's a single parent, so he's got to figure out childcare if he needs to go see the doctor, transportation as well. But let's say he overcomes all those barriers and still gets to see the doctor, gets the exact same blood tests that I do, borderline diabetes. Doctor tells him, you got to eat better, you got to exercise. Of course, he's not going to have the money to do that. There are no fresh food markets in his neighborhood. It's all liquor stores. Can't exercise outside because of the crime and the gangs. And so, as you can kind of understand, my brother, fictional brother, he's probably going to live 20 years less than I will. And none of this, or very little of it, has to do with his genetics or biology. It's really around his circumstances. And so, as you've probably seen, different types of studies and reports, really what goes into our health, only about 20% maybe is the healthcare delivery system. And the other 80%, it's behaviors, it's the environment, it's socioeconomic factors. And so this fictional scenario doesn't even then take into account some of the other influences on health, like the different isms like racism or sexism or bias against LGBTQ communities. And so as a health plan, we focus a lot on the health delivery system side of things, right? Where our job is to make sure our members get the right care at the right place at the right time. But as we talked about, there's so much more that goes into how someone experiences health and gets good health outcomes or bad health outcomes. And so CalAIM is now allowing us to address some of that. Now, as a health plan, as a payer, are we the only entity that's going to work on some of these social issues? Of course not. It's in partnership with some wonderful partners like the counties, like our community-based organizations, faith organizations, the school systems. But now we have some tools that we can use to help contribute to that overall collective work that we're doing to address some of these social drivers of health. And so when you ask about the impacts of CalAIM, and again, I really applaud the state of California and the Department of Healthcare Services for launching this really ambitious new initiative. We've already gotten a number of good outcomes, and here in the United States, we have high quality, amazing doctors. We have fancy hospitals. We have the new technology. We have medications, and I certainly want all of that for myself and my family. But now, we have to start addressing some of these social issues if we really want to get the health outcomes that we all want for our communities and our populations.
Yeah, and so you mentioned DHCS, the significant funding. I think we talked about that in last year's episode. So billions and billions of dollars that have been earmarked for CalAIM and trickling down to plans and providers. I've been doing the home care as my day job for 20 years, and I haven't seen this amount of funding really put out there. And a lot of the care is being delivered, in the home. So you mentioned you have seen some successes, whether it's kind of general successes or even like a specific example. Can you share with us what success has looked like for you in year one?
Sure. So I mentioned the enhanced care management. It's a new benefit, started at the beginning of 2022. It was really sort of a carryover from a prior program called Health Homes. But these, again, are for our highest risk members, the homeless, individuals with severe mental illness, high utilizers that are ending up in the emergency department a lot. And so we've developed a network of enhanced care management teams. Some of them are internal IEHP teams, but most of them are teams that are housed with providers and some community partners. So we now have over 60 of those teams, and these are generally a 4-person team. We have a nurse, sort of lead care manager, a coordinator, a behavioral health specialist, and then a community health worker. And I love community health workers because they're out in the communities, meeting the members or patients where they are, really helping with trust and getting them engaged in the system and navigating the system. And then the rest of the team is there to provide the clinical support, develop care plans and things like that. So we have about, I think, almost 11,000 of our members in enhanced care management now, looking to certainly grow that number. And in that population, we've already experienced a number of great outcomes. So, for example, the percentage of our members in enhanced care management that have their blood pressure under control, it increased from 54% to 72%.
Oh, nice.
Just in the first 6 months or so. Depression response increased from 27% to 39%. So we've had some great health outcomes already from that program.
You mentioned depression response. If I may have misheard, but can you share with us, forgive me for not knowing what that means?
Sure. So we track a few different metrics. One is just sort of documenting depression screenings and making sure that screenings are done for our members to see if they meet criteria for depression. But then if they have depression and they're responding to therapy or to medications and their depression screening results improve, then that's depression response.
Oh, nice. Okay. So double-digit improvement there as well. That's
right.
Cool.
Yeah. On the community support side, we are now over 9,000 referrals. The majority of those are related to housing, and then medically tailored meals are the two biggest in-demand community supports.
Wow. So that's a lot. And those referrals, to those 9,000 referrals are, I'm guessing, to services that without CalAIM may not even exist, right? So for the most part. So
right. We did have, at least through IEHP, a housing program even prior to CalAIM. And that was just something that we supported on our own. But with this funding, we've been able to expand that. So through the CalAIM community supports, there are a number of housing services that we're able to now offer to our members. So there's housing transition and navigation. There's housing deposits. So if a member needs help up front to get into housing, to secure that housing, they need a deposit. We can help with that. There's tenancy and supporting services. So sometimes the challenge is our member gets into housing, but they have difficulties staying into housing if they've been homeless for a long time. So we have support wraparound services that can be provided to help them stay in the housing. There's short-term post-hospitalization housing. So our members that end up in the hospital, if they were prior experiencing homelessness, we can now help with that on a short-term basis. There's also recuperative care. That was also something we did pay for and support prior, but now we're able to do more of that. So that's sort of the housing bundle within CalAIM.
okay, awesome. So one thing I forgot to ask earlier, and I can't recall if I mentioned it or brought it up last year, but IEHP is a county organized health system. I believe I said that correctly. You're referred to as COHS. I've seen COHS. How is a county operated health system like IEHP different than like a, like a Kaiser or Anthem or some of these like big insurance companies that people think of?
Well, so technically we're not a COHS.
Oh, I'm sorry.
So there are, and this is by choice of the individual counties in terms of how they set up their managed care plans. Okay. So a COHS county, and some examples are Orange County, Santa Barbara, San Luis Obispo, some of the smaller counties up in Northern California. But they would be COHS plans, and so they are the only Medi-Cal administrative provider for as a health plan in those counties. We're what's called a local initiative.
Okay.
So, and these are called two-plan counties. So in counties that decided that they wanted more choice, there's a local initiative, which is the public plan. And so on our board of directors, for example, we have members of our county boards of supervisors, as well as some community appointed members. And so we are sort of we're a public plan. And then within our two counties, there's also a commercial plan. Now, here in San Bernardino and Riverside counties, we have roughly 90% of the Medi-Cal population in IEHP, and the commercial plan only has about 10%. So that would be the difference. There's some counties that elected to kind of have it open to as many plans, and they will have 5 different plans, including a local initiative plan, or even more, I think, at one point. So yeah, there are different models in different parts of the state.
Wow, that is really helpful. And I've been doing CalAIM related work for over a year. I thought I had it right on that, and I didn't. So I appreciate the education on the local initiative. So would like, are you familiar with CalViva? Would CalViva be similar, like a local initiative instead of a county organized? Or
I believe they are, yes.
Yeah, I won't hold you to it. Well, thank you for the education for me and hopefully many others. So the populations of focus. So like among enhanced care management organizations, the state has really asked for those groups and for plans to really focus on populations like individuals coming out of incarceration, individuals experiencing homelessness. So we talked a little bit about the housing situation, but are you able to touch on anything that you've seen in year 1 or what's coming down in year 2 with helping individuals that are dealing with those issues?
Yes. So with the incarcerated population or justice involved, one of our counties, Riverside County, there a prior program called whole person care, their whole person care county program focused on the justice involved population. And so we launched that right out the bat in 2022. It's not quite launched yet in San Bernardino County. And so the enhanced care management teams that we're using for that are county-based teams, because with the justice involved population, there's so much coordination that needs to happen with the jail. It's very difficult because Medi-Cal or Medicaid gets suspended when members are incarcerated.
Okay.
And so their Medi-Cal actually has to get sort of reactivated, if you will, upon release. But there are a lot of efforts at the state level to start that process much earlier so that the Medi-Cal becomes active immediately once they're released, and care coordination can happen even while they're still incarcerated. But we have a team in Riverside County that's focused just on that population. And so they work with the jails, they work with probation, they work with parole, they work with the court system, and ensure that the members are trying to achieve optimal health, but also addressing sort of recidivism of them getting back into the jail system. So their coordination efforts are encompassing a lot of different aspects.
Okay, good. That's helpful. So we're now in 2023. You've had year one. You've shared some of the results with us. What is coming down this year that might be a little bit different than what we had last year?
So starting in 2023, at the beginning in January, there were a couple more populations of focus that were launched. And when I refer to populations of focus, these are populations that are now eligible for the enhanced care management benefit.
Okay.
And so the two that we launched were related to long-term care populations. So individuals who were in long-term care but wanted to transition back into the community, and then sort of vice versa, members who are in the community that we want to support and keep in the community to prevent them from going into a long-term care institutionalized setting. So those went live. And then in mid-year, in July, another big population of focus that will be eligible for ECM is going to be the complex children. And that's going to be a very big population. A lot of children that are in the current CCS, or California Children's Services program. So these are a lot of children that have qualifying diagnoses for the CCS program. A lot of sort of complications at birth, certain other diagnoses that make them eligible for that program. A lot of them will be eligible for ECM, as well as the foster population, children with experiencing mental illness, and also children that are involved in the justice system.
Okay, awesome.
So, yeah, we anticipate that will be a very big population that will come in midway through the year. And then at the beginning of 2024, there's another one that's going live, which is the birthing population. So these are going to be expecting mothers who are part of a category that it experiences significant disparities. So, for example, African American mothers who, as a category, as a group, experience much higher infant mortality and birth complications. So they'll be eligible, again, for these same sort of enhanced care management services.
Awesome. And just to make sure our audience is aware, Dr. Wada, for individuals looking for those community supports offerings, like the housing services you mentioned, they don't have to be part of an enhanced care management group in order to apply or be referred to community supports, correct?
Correct. Yes. Yeah. Those community supports are available for any member. On the enhanced care management side, on the community support side, I should say that every plan, those are voluntary. So not every plan will offer the same necessarily community supports. So we went out the bat with 11 of the 14 available. In addition to the ones I already mentioned, there are home modifications, where we can go in for wheelchair ramps, widening doorways, other sort of disability accessories and things like that. Sobering center, asthma remediation. So for our members that have severe asthma, we can go in, and if they have allergy triggers like bad carpets or they need an air filter or something like that, we can now support those types of things. And then midway through 2023, since we were talking about new services, we're going to launch the remaining 3, which will include respite services. So these are for the caregivers, where we can support agencies to come in and help with respite to give the caregivers a much needed break. Dehabilitation services, as well as personal care and homemaker services.
Awesome. So you guys will have all 14 come July. That's great. So CalAIM, we talked about ECM, we talked about community supports and some other things. Outside of CalAIM, we have the public health emergency, that's technically supposed to be ending coming up soon. Can you share with us how that will impact IEHP?
That will impact all health plans for sure, because during the public health emergency, there were not redeterminations. So any member who's on Medi-Cal, they were allowed to stay on without having to verify that they were eligible. Now that the public health emergency is coming to an end, that sort of process is going to resume. So everyone in Medi-Cal will now have to ensure that they meet the criteria for eligibility. So we do anticipate a number of members that are going to drop out because their circumstances have changed, or during the public health emergency, during COVID, they may have lost their job, but now they have a new job, and so they no longer meet the income requirements. So we anticipate probably 10 to 15% possibly of our membership, or really Medi-Cal members across the entire state, may drop out. So there are a lot of big efforts on outreach to make sure our members are aware of that, so that if they do meet eligibility, they can stay in Medi-Cal.
Yeah, that's great that you're making that outreach effort to set them up for success if possible. I didn't realize across the state there were so many Medi-Cal beneficiaries that could be impacted by this. When is the current timeline for that? Do you happen to recall? I know it's this year, but I forgot to look at the month. Do you happen to know?
I want to say it's April or May. It's going to start resuming, not all at once, of course, because there are just so many, but as sort of the anniversary dates come up, it'll be sort of a rolling redetermination.
Gotcha. Well, that's good info for our audience to be aware of. So folks, if you do work with Medi-Cal beneficiaries, be on the lookout. And it's a good reminder to us, Dr. Wada, to also do outreach to our existing members to make sure they're aware of this and how to set them up for success and stay eligible if possible. So, Dr. Wada, really appreciate you joining the show again. Is there anything else you wanted to share about CalAIM, IEHP before we wrap up?
Sure. Maybe just some of the challenges. I think we touched a little bit on this at the beginning. Workforce is a challenging one. Sometimes we have funding and we have these great new programs, but we don't actually have staff to run them, whether it's through IEHP or one of our partners. So workforce is a big issue for us, especially in the rural communities. Yeah. Definitely a big challenge when you have two big counties geographically like we do. Very hard to find professionals in some of those outlying areas. So, big workforce shortage issues there. And then just trying to increase awareness and utilization of these programs that they're in place. We love to see increased numbers, both in ECM and referrals into community supports. We're doing a lot of efforts around engagement. So a lot of our members, they don't even go in and see their doctor, so they're not even aware that these new programs exist. So doing a lot of work around engagement, using community health workers and other means to try to really get out into the communities where our members are to ensure that they're getting information from a trusted source. Yeah. So a lot of work around that. And then just an overall big focus on quality and really trying, the point of all these programs is to ensure that our Medi-Cal members are getting access to high quality care, getting the preventive services they need and deserve, and so that they can experience great health outcomes and be productive members of society. So big push on moving the needle with respect to quality metrics.
Yeah, quality is always. I've attended a few of your board meetings, and I do know I can tell it's a big focus of you guys, as it should be with all of us.
Yeah, so, and related to that, looking at disparities in health equity, because even when we look at those metrics, there are certain subpopulations where the outcomes are disproportionately worse. So trying to find innovative ways to reach those populations as well.
Yeah, that's great. That's great info for those that weren't aware of those issues. I know a lot of part of the states are experiencing the similar challenges, but thank you for sharing that about your two counties. Anything else, Dr. Wada, before we wrap up for today?
No, I think that's it. But again, it's an exciting time. There are a lot of new programs, even outside of CalAIM. A lot of funding coming down for housing, for behavioral health. We have a new initiative where we're partnering with schools to increase behavioral health capacity. As you can imagine, through COVID and well, even before COVID, there were challenges with our children and youth and behavioral health issues that was magnified during COVID. So a lot of great new partnerships and working with schools and educational institutions around that. So a lot happening in Medi-Cal right now. It's an exciting time.
Definitely an exciting time. And I haven't been involved in the Medi-Cal population much until just 2022. And it's funny, I've been with my day job for 12 years, and I've never been more motivated because, like you said, the CalAIM initiatives, it's super exciting. A lot of opportunity to impact lives. So thanks, Dr. Wada, again, for joining the show today and for IEHP making this happen. Again, Dr. Wada mentioned, folks, if you're interested in learning more about IEHP, check out, I believe it's IEHP.org. Inland Empire Health Plan is what it stands for. Dr. Wada, thanks again for joining today.
Great. Thank you for having me.
Thanks, everyone, for tuning in to another episode of PopHealth Podcast. We hope you've enjoyed today's episode, and if you have and want to check out other episodes, visit us at pophealthpodcast.com, iTunes or Apple Music, Spotify, Stitcher, and now YouTube as well. Take care.